Afternoon, everyone. Thank you for joining us today. I'm Avital Havusha. I'm the Vice President for Programs here at the New York Health Foundation. We're really excited to start this conversation today to address the health challenges and opportunities in rural New York and ways that we might be able to address them. But before we get started, I just wanted to cover a few housekeeping items. We will be recording this webinar and a recap with the link to materials and the slides will be circulated within a few days after. The video and audio are disabled for you as participants, but we do invite you to participate through the chat box throughout the event to share any questions, and we'll be addressing those questions after some brief presentations at the top of our session. And we also have closed captioning available. You can see a link to that feature at the bottom of your screen. So just to set the stage for today, in September, the Office of the New York State Comptroller released a report examining some of the demographic, economic, and quality of life trends in a sample of 10 rural communities in New York State. Those communities, they comprise just 2% of New York's population, but more than 22% of our land area. And the report's findings, which we'll talk a bit more about today, highlight some of the characteristics and the challenges that face rural communities and really lift up some of the gaps and potential solutions. So I encourage you to take a look at that report if you haven't already. We'll be providing a link in the chat and feel free to share other resources that you think might be relevant to the group. And today we'll really use that report as a jumping off point for some discussion. Our speakers will provide us some of the top line takeaways. They'll outline some other priority areas that might not have been covered in the report itself. They will really delve into, for us, some of the structures, infrastructure, and policy on the ground that anchor our rural communities here in New York, which will include some of the gaps and opportunities for expanding and enhancing some of those structures. So I want to leave us enough time to cover all of that ground. So I'll introduce our speakers for today. And I'm really pleased to welcome all of our speakers. Feel free to show your cameras now. So first, we're really honored to have them join us. They've been wonderful partners of the foundation. First, we have Maria Dulis from the Comptroller's Office. She's the Deputy Comptroller. And Tom DiNapoli's office, Josh Simons, Policy Director in the Comptroller's Office, Allie Coates, who's the Vice President for the New York State Association for Rural Health, and Claire Pardee, who is the Executive Director of the Healthcare Consortium in Columbia County. So we'll be running through some brief presentations with some slides. I'll be sharing my screen, and then we'll have time for discussion at the end of that. I'll facilitate some questions that we prepared, and you can also share some in the chat. So bear with me for a moment. I'm going to turn it over to Maria. I'm going to just share my screen so that you can see her slides.
Thank you. Thanks for that introduction. I'm really excited to be participating in this discussion with our colleagues here. I think most people know Tom DiNapoli is the state comptroller, and they know he's not a policymaker. He's the state's chief financial officer, but he has a policy shop, which I lead, which he uses to highlight the issues that he thinks are of critical importance and really merit greater attention from people and policymakers in the state. And so we have done work in our shop on items, on issues that affect people throughout the state, like drug overdoses, poverty, broadband. And in the course of that work, what we started to see was that, while these are universal issues in some ways, the flavor and the dimensions of the problem in rural communities felt a little different. And so he said, we should do a report that really focuses on the challenges faced by rural communities. And so that was the impetus for this report here, which, as Avital said, was released last month. And so I think to those who have been following and really, know these issues, there's nothing here really new or newsworthy. I think, there's certain merit to bringing it all together, but what we kind of concluded, and I think was really important to emphasize as a message of this report, was that oftentimes, policymakers are on it. They're aware, they're trying to advance solutions to these problems, but they're really crafted more to be viable in urban areas. And you kind of can't take those solutions and copy paste them, onto rural areas and expect it to be really fruitful. And so, that's sort of one of the bottom line takeaways of this report. You can go to the next slide, Avital. So, there are rural areas across, counties, across many of the state counties in New York. We wanted to look at this through a very kind of analytical benchmarking type of a lens, a qualitative lens. And so we restricted our analysis to counties that, according to the federal government, are unaffiliated with any metro areas. So metro area typically has a principal city, and then the surrounding areas and counties that are part of that economic ecosystem comprise the metro area. So these are counties that are not part of the metro area, and furthermore have no city with a population greater than 10,000. So when we were kind of putting this all together, it became clear that there were the challenges that we were really starting to lay out and identify, but in many ways they were rooted in certain common circumstances. And the first, as Avital said, is that, low population densities across really vast terrain. So 2% of the population lives in these 10 counties, but it covers more than a fifth of the land area of New York. In some cases, that terrain can also be maybe difficult to navigate, mountains, bodies of water, farmland, etc. The demographics on the ground have been shifting in these communities too. So population has been in decline, population loss of about 3% in the 10 rural counties compared to population growth of 4% in the state from 2011 to 2021. And while that's happening, the population has been getting older. So these counties aged at a rate double that of the state. So the median age is 45.8 compared to less than 40 for the state. Some of this is frankly related to the economic realities on the ground. So in some of these communities, we've seen long-term job loss. There's certainly, in the aggregate was, some job loss in the last decade, a shrinking labor force participation rates lower than the state, which, the state is by no means a leader in the participation rate relative to other states anyway. So pretty low connection to the workforce. And then finally, due to these low population densities, there's not really much in the way of available or useful mass transit. So we see really heavy reliance on personal vehicles. And similarly, less or no connectivity digitally, particularly with respect to broadband, but in some areas, even cellular service, right? Next slide. So while our focus here today is health, I thought it was worth mentioning some of the broad categories of other things we covered, just because these challenges are all related and they tend to compound and amplify each other. So one category was housing, and here, similar to population decline, we found there was a decline in housing units in the rural communities and very high vacancy rates. So vacancy rates that were in excess of 30%, 3 times more than the statewide average. And so the implications of this are really about affordability on the ground and the pressures that puts for the folks who stay and where they can find housing and of what quality. Second area we've touched upon already, broadband. Quite frankly, while the state has done well relative to other states, we have not, broadband has not really been deployed with great success in rural counties. And so while 97.5% of addresses statewide are wired for broadband, more than 10% are not in broadband communities. And in some of the counties we looked at, that share was about 30%, as high as 30%. So really a lack of availability for something that has become very critical infrastructure. And then our third category was health and welfare. And so we looked at many things in this space. We did examine poverty, food deserts, access to elder care, but the focus here for today will be looking at some of the findings we had related to health access. Next slide. So I think for many people on here, they're familiar with some of the concepts and the ratios that I'll present here, but fundamentally what the data which is from the federal government show, is that there is really hard time accessing healthcare in many of the rural communities across the state. So we use two types of federal metrics here to probe this issue. One is what's known as the health professional shortage designation, right? So these are areas where the number of health providers available is small relative to the population in the area. And so, for example, in Delaware County, you have 30,000 Medicaid eligible people for every one primary care provider. This is huge, huge imbalance and shortage in that area. These shortage areas are examined and indexed by the federal government according to three categories: primary care, mental health, and dental care. And so when you look at the scan, it seems that the shortages are most acute in dental care and also in mental health. The second set of indicators and category relates specifically to primary care, and it's what's known as areas designated as medically underserved, or populations designated as medically underserved. These specific populations include the Medicaid eligible, low income folks, the homeless, migrant farm workers, Native Americans, and maybe a few others. But so there are these two dual designations related to place and people. And so that's what you see mapped here on your left. Our 10 rural counties of focus are outlined in the darker black. And what you see is that you have counties such as Hamilton in the north and Schuyler County in the southern tier, where almost the entire county is designated as medically underserved. In other places, Greene County, for example, there are populations that are underserved almost across the span of that entire county. So some very real shortages there. Some of these counties lack hospitals. There are others where the hospitals that do exist have had to downsize and eliminate some key services or functions. We're reading a lot now about maternal care and closing of maternal wards and hospitals throughout the state. I will say, I took a gander at some of the data around health professional shortages. So where there is a designation for a primary care shortage of health professionals, they do a secondary score on maternal health. And several of these counties also had shortages in that specifically. So this is all about the individual being able to access healthcare. There's also a challenge when it comes to the inverse in terms of the healthcare coming to you. And what I mean about that is EMS. This has been is sort of a service provision that is becoming increasingly challenged throughout the state. And one reason is both for funding and for staffing and volunteer purposes. And my colleague Josh Simon, who's on the panel, can definitely talk more about that later on. Next slide. And so the other part of the data that I really wanted to address and unpack was about drug and alcohol treatment. And so we had done a report just documenting the surge in drug overdose deaths in the state through the pandemic. That's been driven very much by opioids and synthetic opioids in particular. The provisional data for 2022 show that increase has continued through this time. And when we look at the data for the 10 rural counties, the death rates from opioids were higher than the state rates. And the admissions rates to treatment programs in parallel were also higher. And so the crude rate of admissions was about 500 per 100,000 people. In the state, it's about 450. And this is really despite the fact that in some cases there are really limited treatment options. So we did, our survey, and while there are really robust systems in care in some parts of the state and the counties we examined, there were no outpatient treatment programs. There was one crisis treatment program, one inpatient treatment program, and some of the counties had residential treatment programs. Changes were made during the pandemic to try to address some of this with telehealth services, but some of the rules related to that I'm sure my colleagues can address have lapsed or have expired. So you can go to the next slide. So our report lays out some of the current policies, some of the funding in the budget related to rural communities, and assesses that a little bit. I'm not going to get into it. I think my colleagues on this panel can give you can address that with much greater wisdom and specificity than I can bring. I'll tell you that we identified what we thought as some pathways to be able to tackle the some of the root challenges to these problems with downstream effects for everything, including and especially health. And we really focused on the prospects for improving connectivity in terms of transportation, but also digital connectivity to mitigate the challenges. And again, I think the key word here is mitigate. It is not solve, it is mitigate, it is supplement, it is not supplant or replace, because I think we're very clear-eyed that this can be part of a solution, but not the whole solution. And so the final comment that I just wanted to make and offer, just as perhaps helping to guide our conversation as well, is, we talk about, well, some of these persist because even if funding or policies or action has been taken, it's really not, done uniquely or specifically with rural community challenges in mind. I think there was a recent example that can be helpful that shows where there's a shift or a tide or what happens when it looks differently. And so I think the pandemic, there are many challenges laid bare during the pandemic and pre-existing challenges that were heightened. I think one thing that it made absolutely clear was the importance of broadband to everyone to be able to kind of access modern services. And so while there were pandemic era programs that did all kinds of things, subsidies, grants, infrastructure, et cetera, in the IIJA, the bipartisan infrastructure plan, there was a big new investment in infrastructure, broadband infrastructure, that is specifically intended to serve first and foremost unserved areas. And so now New York State has been awarded funds to develop a plan to get the broadband to these unserved areas, which we know are predominantly rural. And I think another nice thing about this program was, not only the recognition that that's how the funds had to be targeted, but a recognition that it was going to cost more, that there were higher cost allocations baked into the formula and the funding in recognition of the fact that this is more challenging and it will take more to accomplish this goal. And so here is a case where we see a real demonstrated need, a recognition of the challenge, the political will leading to the funding that is tailored to the specific communities. And now, of course, we'll see what happens on the execution and the implementation side. But I think it just shows the kind of focus, when the focus comes with the funding, how it could potentially be impactful. So that's it for me. I look forward to hearing from my colleagues.
Thanks, Maria. So we'll pass it off to Allie. I'm sorry about that. I think I had some echo. So Allie, I'm pulling up your slides and go for it.
Great, thank you. I'm Allie Coates. I'm Vice President of the New York State Association for Rural Health. And I'm really grateful to the Controller's Office for bringing rural issues to the fore with this report. While it is crucial to shine a light on the challenges and the injustices that we face in delivering health in rural communities, focusing predominantly on all the ways that rural areas are difficult places to live and work and play doesn't really help us to build up and attract people to work and live there. So this deficit perspective does play into and reinforce the idea of rural decline. And I would encourage us all as stakeholders and advocates to remember that rural challenges are just part of our lived experience and that we have plenty of strengths and assets as well. That said, in order to make change and to help strengthen our rural health systems, we do have to acknowledge the various challenges that we face on an ongoing basis. Each year, NYSAR works with its partners and allies to draw attention to timely and chronic issues that affect the health of our rural communities. We talk every year about access to care, about the difficulties recruiting, retaining, and supporting a diverse and sustainable health workforce. We talk about transportation needs, and ongoing inequities in access to broadband and cellular services, which the controller's report noted. We talk about the challenges that our emergency medical services providers face in transporting more people more often over longer and longer distances. And we talk about the various infrastructure needs of our rural health facilities and services. Next one. At the root of many, if not all of these challenges, is the fact that our health system evolved to suit the majority of the state, the cities, and that the system just doesn't fit our rural areas that well. So the health system's built to reward a set of assets that just don't align with the core strengths of our rural areas. The system rewards volume, it rewards efficiency, it rewards economies of scale. But with smaller and sparser populations, the basic assumptions that the health system builds in just don't apply. Rural communities have tons of assets and strengths that we need to leverage to strengthen our health systems. We're resourceful, we're innovative, we're tenacious, maybe stubborn, and we have strong social connectedness within our communities. So we need opportunities to build solutions that make sense for our communities. We need solutions that meet rural needs, that use rural strengths, and that value rural resources. And so I want to point us back to one of the first slides that the Controller's Office had, which stated that solutions that are effective in urban communities may not be well suited to rural ones. And we can't just necessarily scale down urban programs and hope that they work. Rural communities are not just cities, but smaller. We need mechanisms within our health system that allow us to do things differently, to innovate and to iterate until we find solutions that fit.
Thank you, Allie. So we'll turn it over to Claire, and then we'll kick off our discussion from there.
Great, thanks, Avital. My task today is to talk a little bit about the New York State structures and programs that support rural health. I think we've heard from some of my colleagues on the call that it is incredibly important to focus on rural people and places. In order to successfully program in those areas. And there are some entities in New York State that do this, and I'd like to talk about those just a little bit. So really, I think about 3 different structures in New York State that focus on rural. One is the Rural Health Council. The other is a Legislative Commission on Rural Resources, and then the Charles D. Cook Office of Rural Health. And I'll talk a little bit about each. So the Rural Health Council is responsible for advising the Commissioner of the New York State Department of Health, State DOH, with respect to all aspects of rural healthcare and rural healthcare delivery, including, but not limited to, the impact of proposed programs, statutes, regulations, and healthcare reimbursement policies. The Rural Health Council has existed for many years, but it's fair to say it's been on hiatus for the past few. It's currently being reconstituted to comply with legislation that changed the way in which the members are appointed. Almost all the members are seated at this point, and there's an expectation that the first organizational meeting of the Rural Health Council, the reconstituted Rural Health Council, will occur either by the end of this calendar year or in the early part of 2024. There's also the Legislative Commission on Rural Resources. So this is basically the New York State Legislature's body that focuses particularly on rural people and places. It was established by the legislature in 1982, but it is a bipartisan commission, and it's charged with examining the impact of rural resources on the state's economy, reviewing existing laws and regulations as they relate to rural resources, and assessing the effectiveness of programs designed to promote rural viability. So it's a 10-member commission, includes 5 state senators and 5 members of the assembly, and they shape the agenda of the commission to sponsor legislation, recommend policy, and promote efforts to enhance and protect New York's rural resources in a way that benefits rural communities. And I will say that my own direct experience of the Legislative Commission on Rural Resources has been really positive. Like Allie, I'm on the board of the New York State Association for Rural Health, NYSAR, and we rely frequently on the expertise and the partnership that's provided by the Legislative Commission. Next slide. And then there's what I think of as the biggie, which is the Office for Rural Health. So this is the Charles D. Cook Office for Rural Health, which actually resides within the New York State Department of Health. And it's really responsible for rural health policy and programs that are aimed explicitly at improving health in New York's rural places. So there's really 4 different programs that are overseen by the Office of Rural Health: the Rural Health Network Development Program, the Rural Healthcare Access Development Program, the New York State Rural Hospital Flexibility Program, and the Small Hospital Improvement Program. And I'll have a little bit more detail about those. So the Rural Health Network Development Program provides funding to help develop formal networks of health and human service providers in various rural communities throughout the state. So right now there are about 32 rural health networks serving nearly all of New York's rural counties. And the purpose of all the networks, the fundamental charge of all rural health networks, is to identify strategies that strengthen both local healthcare and local public health systems. And I like to think of rural health networks as sort of a ready-made vehicle for responding to the pressing needs of our state's rural communities. Their strength is that they actually have a considerable amount of flexibility, and so they can develop what we might think of as homegrown solutions that rely on both an intimate knowledge of a community and also leverage local relationships. And I will say I'm a little biased with respect to rural health networks. The Healthcare Consortium, for which I serve as the director, is in fact one of the 32 rural health networks in New York State. So not dissimilarly, the Rural Healthcare Access Development Program, it's almost like the counterpart to the Rural Health Network Development Program, but it's focused instead on New York State's rural hospitals. So currently, that program provides funding to New York State's 44 rural hospitals. And the goals are really to reduce duplication of services, improve operational efficiencies, and develop affiliations with community-based providers. There's a lot of different things that can, the different kind of program activity that can fall underneath the Rural Healthcare Access Development Program. But again, remember that it's really focused on rural hospitals. I mentioned the New York State Rural Hospital Flexibility Program. This is the program within the State Office of Rural Health that's funded on CAHS, critical access hospitals. So currently there are 18 critical access hospitals in New York State. That's a very particular, both federal and state level designation. And this program focuses on a number of things, implementing programs and educational forums to improve financial and clinical performance of CAHS, improving collaboration and cooperation between hospitals. But probably the most important thing to remember is the State Office of Rural Health coordinates the New York State Critical Access Hospital Performance Improvement Network, which is really a network of all the 18 CAHS in New York State. And lastly, that Small Hospital Improvement Program, otherwise known as SHIP, right now it funds 22 rural hospitals to help them meet value-based payment and care model goals. So there's a lot of funding in this particular program for rural hospitals to do acquire and software and hardware, and also provide training on software or hardware that help hospitals to participate in value-based payment arrangements. So those are the 4 principal programs that come out of the State Office of Rural Health. The other thing that's important to note is the coordination between the Office for Rural Health with other entities within the Department of Health. So the department has a Division of Workforce Transformation, and also the newly created Office of Healthcare Workforce Innovation, both of which sit inside the Center for Healthcare Policy and Resource Development. And so they all have somewhat separate charges, but they all work in close coordination with the Office of Rural Health to make sure that a rural lens is applied and that there's always a focus on rural people and places. Additionally, the Office of Rural Health works with the Office of Public Health and the Office of Health Equity and Human Rights on some of their initiatives, again, to make sure that there's that kind of focus on rural people and places. Thanks, Avital.
Great. Thanks. I'm going to stop sharing my screen, but we can, if anyone needs us to pull back up some of the structures that Claire mentioned as a reminder, we can do that. Great, thanks so much. So I'd like to invite all of the panelists back so that we can have some discussion. As you can probably see, there are a fair number of questions already in the chat, but we had some that we want to kick off, and we'll be continuing to monitor that. And I think a few of the topics might have been covered a bit. So I'm going to start with one question, and then we'll continue to bring some of the audience questions in. So I wanted to just dig a little bit deeper into something that you all mentioned throughout your presentations around some of the challenges about kind of pasting urban solutions into rural areas. Maybe we talked about that more thematically. Can you share, I think, Allie and Claire, you might have some examples of how that plays out in practice, whether it's, things around the types of grants, block granting, or bricks and mortar issues or things like that. Maybe you could just touch a little bit on what that looks like in practice.
Sure, I'm happy to start and yield to Allie. I do think that generally block grants are pretty unfavorable to rural areas. Actually, Allie said it beautifully. The system is sort of set up to reward volume efficiencies and economies of scale. And, we understand that, but at the same time, that almost means that rural areas very rarely competitive in those block granting scenarios. I can, a very concrete example is that OASIS, the Office for Alcohol and Substance Abuse Services, tends to have competitive procurement opportunities by economic development zone, which are usually like 8 or 10 county regions. So it's very challenging for smaller rural providers that might have a mandate to serve 1 or 2 counties to submit a reasonable application for funding to serve such a large area. This is true of my own network. I don't have a mandate to serve a 10 county area. I have a mandate to serve a 2 county area. And just in general, I would, and you talked about bricks and mortar. There are a lot of models that are getting a lot of attention recently. I'm thinking specifically of crisis stabilization centers. Well, that's, a very expensive model of service delivery that is dependent on volume. And rural areas just can't generate the kind of volume that are necessary to make those kinds of endeavors economically viable. So in general, I would say that, if I had a prescription, it's for flexibility in the funding opportunities so that we could have an opportunity to innovate and iterate, as Allie said. We do have the local level knowledge and relationships that we can leverage to make to do some very successful program delivery. But we are currently a square peg in a round hole. Thanks.
Allie, did you want to jump in at all?
Sure. Claire really hit the nail on the head there, that anytime that you have a situation where you're paying for volume, right, where you're paying for services by the services rendered, it makes it harder for us in rural areas. And I think people who are traveling in rural areas see this very quickly. If you're doing home visits and you have clients that are 20 miles apart, you can't drive 20 miles more efficiently to get more clients in a day. That is just an inflexible portion of your equation. But if you're, working a high rise, you can walk from one door to the next in about 20 steps and hit multiple people in the same day. So I think that's an example of, how having fewer people and having them further apart makes things harder for us. And I know that we hear this all the time from our rural folks who are traveling, especially. I think another place that we see it is in value-based payments that hospitals have, and that regions have embraced, is that it's really hard to show big differences over small populations, harder than showing small differences over large populations. So you can show an effective change much faster, much easier when you have a lot of people to get those numbers significant. So I think that's one way that the rural hospital systems in particular and the rural ACOs have really had a challenge in the last decade of trying to meet this paradigm of delivering value-based payment or getting value-based payments or delivering value-based care, because it's not that we don't want to do good care. It's not that we don't want to, do better. It's that showing that difference is a lot harder in the population that we serve.
Thanks so much. No, those are really helpful framing. And I think one other point I want to that relates to some of this that was a through line with all of your presentations, and then it also kind of touches on some of the comments in the chat, is obviously the rural workforce, the strain, some of the shortages across the board, some of the potential solutions that whether it's telehealth or other ways of kind of shared resources. And I just wanted to maybe hear a little bit more from all of you. This is all of these topics we could do an entire webinar on, but maybe you could share some of the key challenges and tensions that are emerging around workforce. What are some of the most pressing issues, and maybe some of those unintended consequences even behind some of the tele solutions? So I'll start with Josh. Maybe you can give us a bit of some thoughts about some of the economic drivers, and then we'll go into some of the issues at hand.
Yeah, so with regards to workforce, one of the things that we see is we see this sort of cyclical spiral where basically due to lack of opportunities, younger people especially move elsewhere. Like in the 10 rural counties we looked at, there were very few colleges, for instance. So if a person from this area wants to go to college, they have to leave the area. Economic opportunities, because the economies have stagnated or contracted, over time, there are fewer opportunities for jobs, which makes people leave elsewhere. Now, this perpetuates the cycle because it decreases the available workforce. It also decreases the consumer base. It makes running small mom and pop retail locations, small businesses much more difficult, which then causes decreased opportunities. Now, at the same time, we have declining housing stock, both in the number of housing units available, but also the age and quality, right? And so you could plop down jobs in these places, but if there aren't places for people to live, to work those jobs, then you're not going to attract a workforce. And paradoxically, you also have these vast sort of less dense areas where the transportation options then are incredibly diminished. Even if you are commuting to this fictional job we just plopped down into a rural setting, the distance between where you can find housing and where that job is can be prohibitive. And all of these things sort of feed this sort of lack of opportunity and the increasing people moving elsewhere, the declining populations and things along those lines. At the same time, the people that are staying are older, they're more established, they own their houses. And so while we see relatively low unemployment and poverty, we also see really low labor participation rates. So like the people that live in rural places generally, like not universally, absolutely, but generally can afford to live there, but they tend to be older, and there's a bunch of like implications to that. Transportation becomes one, because as people grow older, their ability to get themselves from point A to point B is diminished. Then there's also like the issue of older people require more healthcare. I mean, that's just kind of, I think all of us can attest to that at some point. And so, that's another particular sort of issue. And then, we have this vacancy rate issue with the housing, where in the places that we were looking at, one of the drivers of vacancy are people's second homes and vacation properties and short-term rentals and things along those lines. So when balancing a need to attract a workforce, particularly healthcare jobs, which is, one of the major employers in pretty much all of the rural counties and or suburban counties for that matter, you end up with like these basically self-perpetuating cycles that there are barriers and impediments at every step. Yeah, so that's my basic spiel on the rural workforce.
No, thank you. No, you gave us a good sense of some of the tensions. Allie, do you want to jump in and maybe talk specifically about some of them?
Yeah, I want to note that it's not just a matter of attracting people to rural areas and keeping them there. There's a health workforce issue across the board. We just don't have enough people. One of the things that happened during the pandemic is that we needed to pull workforce from, areas of low COVID burden and put them in areas where there was a high COVID burden. And to meet that need, we often ended up with these staffing agencies recruiting people from our rural areas, sending them off to the cities, and then we had holes in our workforces. And we had to fill those holes by going to those staffing agencies and paying now much more for the workforce that we already had. And I think the part of the problem that we're seeing, and this is not just in New York, this is across the country, this is across the world. This is a global health workforce shortage right now, where we have been recruiting people from other places to fill our holes. We recruit from other countries to fill our workforce gaps. And we need to be developing this here. We need workforce development programs in every rural community so that we are providing opportunities for good jobs in the places where these people are living and where there is a need and where there is an opportunity to serve. So I think our approach to the health workforce has to be holistic, and it has to be intense, and it has to involve local development.
Thank you. That's helpful. Claire, was there something that you or Maria that you wanted to share on this topic?
I think I would just add that, what this all translates to in practice is the reduction in services to the residents of our rural communities. I mean, so much of health and human services, I mean, they're people powered. And so as we have lower labor force participation, we literally don't have the people to power the services. And so the health of the community actually starts to decline. And I have local examples. We've had real difficulties adequately supporting our behavioral health system in my area because of vacancies at, in every conceivable job title across that system, that particular system. And as a consequence, the people are receiving less care and their acuity level increases, their inpatient hospitalization increases. I mean, you see the effects throughout the system. So there's a real fallout. These are not academic concerns. There's a real practical implication to the health workforce challenges. And that's in the overall health and well-being of our rural people diminishing, and with a lot of accompanying hardship as well.
Yeah, and I think one of the things I know, thank you, that we talked about in terms of, one of the other dynamics at play is, and it'll lead me into some questions from the chat around the telesolutions, whether that's telehealth or otherwise, that, in many cases, it's been a real opportunity to reach people who might not have otherwise have access. On the other hand, there are some challenges around what that might do to the kind of in-person workforce and even potential drains on the workforce. So I'm curious, and we do have actually a question in the chat also about some access to telehealth and school-based health center settings, which we can maybe follow up on. But I'm curious to hear a little bit more about what you all think about that dynamic around telehealth and other telesolutions. So I'll start there. And then there's another question about just going back to this broadband question. How long might it take for us to see those federal dollars come to fruition? So let's start with the telehealth solutions. And maybe, I don't know if Claire or Allie, you want to jump in?
Thank you. So telehealth, of course, was accelerated very rapidly when the pandemic hit. All of a sudden, something that we had been talking about as like, oh, wouldn't this be nice someday, was everywhere. And it very quickly highlighted the gaps in rural areas to access, because here was the solution that was going to solve healthcare access. And instead, it exacerbated all of these disparities in access, because we realized very quickly when kids were going to school online that, the kids didn't have access to the internet that they needed at home. They were sitting in parking lots. They were going to, public facilities to access internet, and sometimes really far away from their own homes. And this is something that those of us who live and work in rural areas kind of already knew, because I remember talking to some pharma companies about a clinical research that we were doing, and they had these like mobile devices, and this was about 8 years ago. And they were like, oh, it's great. So people can just fill out their diaries from their home. And I was like, yeah, that's really funny, but we actually don't have cell service for them to fill out these diaries at home. And so our patients were then driving into our health center to fill out their home diaries at the health center. And so it's a real disconnect, because there's this assumption that the services exist. But then when it comes down to it, in a lot of places, they don't. So it complicates the workforce issue, right? Because the more that we can rely on services being delivered from somewhere outside of our communities, the less we have those people inside of our communities. And when you think about what makes us a healthy and supportive environment for health workers, it's peers. It's, you know, having a community of health workers around you. If you're a physician looking to move to a rural area, you want to know that there's other physicians there who are going to, you know, be able to be your community. So the more that we rely on people who are elsewhere, the more it makes us dependent on other people who aren't connected to our community remaining invested in providing that. And we've already talked about economies of scale, and you know, if somebody doesn't have a mandate to serve a specific community, why would they keep doing it? Right now, the incentives are there. Right now, the payment mechanisms are there. But when all of our pandemic stuff starts to expire and our provisions for telehealth start to go away, there's no guarantee that those reimbursements are going to stay. That's something that we're advocating for right now, is to make sure that the telehealth services that we have benefited from remain sustainable. You know, we just have to keep in mind that serving a rural community involves being part of that rural community. And if you don't have that tie, there's nothing to keep you there if the money stops.
Yeah, no, absolutely. Thank you. And I think there's a few interesting comments in the chat, kind of making some of, you know, a bit of those comments around the relationship between the workforce and housing, and, you know, some of these issues around telecommuting. Might someone live in the community but be kind of working somewhere else via some kind of work from home situation? So I'm curious, I don't know if Maria or Josh, if you have a sense of that, the kind of promise around the broadband access, if any insights about, you know, what that might look like in terms of timeline, or you know,
Yeah,
getting those rural communities up to date.
Yeah, I can't answer timeline. I'll give you sort of the state of play right now. So New York was awarded 665 million under this BEAD program that I mentioned, and the program has a sort of set of milestones. So right now, the state, through its Connect All office, has released its sort of first salvo, which was supposed to be sort of like a needs assessment. And, you know, there were a couple takeaways from that report. One of them was, well, if we're going to wire all the unserved areas, it's going to cost us a lot more than $665 billion. So I think what you know, what they state as the intent now is to say, okay, we're going to think about how to do this with various technologies that would achieve the outcome, but may not be the fixed deployment, right? So get the service, but not necessarily commit to the technology. And so the state has to submit this very detailed plan to the federal government in December. That will unlock 20% of the funding if it's approved. And then it'll submit its final plan a year after that date, with, you know, more concrete deadlines. And then that will unlock the remaining 80%. So, you know, it's sort of, they're just starting, I would say. All of this is contingent on federal approval and meeting the standards and demonstrating that the approach is thought out, and reporting on metrics and other things that are part of the accountability that the NTIA wants to put in place. So I would say, even if they have a successful strategy laid out, we're still a couple years out.
Got it. Thanks. That's helpful. And then I just want to jump into a few. We have three more topics we really want to try to cover. One, just pulling from the chat a bit about something that Allison mentioned at the beginning around kind of avoiding a deficit framing and thinking about the strengths and assets of communities. So I just wanted to hear a bit more, if you could talk a little bit more about those strengths and assets. And a related question that came in from the chat was, what are some of the efforts happening around engaging community members and residents around some of the solutions, which I expect is one of those assets. So maybe we could speak to that a bit. I don't know if Claire, do you want to kick it off?
I'll take the second question
Great.
first and then point back to Ally because I know she'll speak
Perfect.
brilliantly to the first. So as I mentioned earlier, the Healthcare Consortium is a rural health network. And like a lot of rural health networks, we engage directly with our local departments of health and our hospital system, hospital-based health system, to do the periodic community health needs assessment. So both the New York State Department of Health with regard to the local health departments, and actually the IRS with regard to the hospitals, requires that these institutions or entities conduct community health needs assessments every 3 years. So with regard to the participation of local residents in that process, a couple of things. First of all, they're counted in the sense that a lot of those needs assessments rely on public use data sets. So, you know, the typical things like decennial census and American Community Survey, but also, you know, sort of health specific surveys like behavioral health risk factor surveillance survey and so forth. The other thing is that a lot of needs assessments will conduct survey research and sample from the community. So that's that. The other thing is that community health needs assessment then feeds planning processes. So on the parts of the local departments of health, they're charged with creating what's called a community health improvement plan, or CHIP. On the part of the hospitals, they're charged with creating what's called a community services plan, or CSP. But they're very similar in a lot of respects. And both planning processes are really meant to engage stakeholders. For the way that we conducted that work in my service area, Columbia and Greene counties, is aside from administering surveys, we also held public meetings to try to attract residents to come and inform some of the decision making. The reality is those planning processes are really a narrowing of interests. I mean, we start with sort of like the universe of health problems that plague rural people in rural places, and then ultimately boil them down to like 1 or 2 health issues that we're going to focus on. And, that's sensible from a planning perspective, in designing interventions. But, it's really important to get the input from a broad array of stakeholders, including, average Joe and average Jane from the community, about the things that are of real concern to them. Because, the stats are not the whole story. Mm-hmm. What we think of as the most pressing health issue is maybe not this, one and the same with the issue that causes the greatest amount of fallout or hardship for our rural residents. And so sort of taking their lived experience and their perspective into account is really key. Hope that helps.
No, that's great. And Al, do you want to jump in a little bit about kind of the strengths that you see?
Sure. I don't think that I can speak for all rural areas, because one of the things that we have to keep in mind is that there's lots of rural areas and they're all different, and they all have different communities, and they all have different assets. So there's no set of rural assets and strengths. Yeah. But the point of pushing back against the deficit view is to understand that if you focus all the time on the things that you lack, you don't draw from the things that you have. Mm-hmm. So I'm encouraging folks in communities to understand what's there, understand what can be used and be put into action. And I think that the system that has been developed as, a fundamentally urban system really doesn't give us the flexibility to use all of those assets and all of the innovative and resourceful ways that we could potentially do. There are different ways of doing things. There are different ways that healthcare is delivered across the world. If we had a little bit more flexibility in how we could serve our communities and take an approach that is more about, it's a salutogenic approach. So instead of focusing on pathology and on, the conditions that create disease, you focus on the conditions that create health. So that's the concept of salutogenesis. And I think that if we can take that type of approach to our rural communities, then we come in with a building mindset instead of a mindset of how can we pare things down? How can we take more away? So I think that's what I mean by embracing the rural assets. There's not one set. I can say that, for most rural areas, we're resourceful, we're innovative, we're doing things differently, doing without certain things all the time. But there's more, and each community is unique, and we need the flexibility to be able to do what works for us.
Absolutely. And Josh, that's really helpful. And I think also a nice capstone for our discussion. Josh, did you have anything to add there?
I mean, basically my point is that was echoing Ally's
Yeah.
perfectly, which was that we so often define what is rural by what it is not. It does
Mhm.
not have population. It does not have density. It does not have a robust economy. We don't define rural by what it is, and which is a very strong interconnected senses of community and place, identity. There's strength to that. There's absolute strength to that. They are not monolithic. My family
Mhm.
originates in Wells in Hamilton County, which is extremely rural, among the most rural in the state, and yet is completely different than Wyoming County or Greene County for that matter, even though Greene County's in the Catskill Mountains. The Adirondacks is another beast. And so not only can you not cut and paste solutions from urban settings and just drop them into rural places and think that everything's good, you also can't develop a solution for a rural place and assume that it's going to be universally applicable to all rural places, because that's just not the way this works. And so like the emphasis on bottom-up solutions is the absolute key here. And it's identifying the assets and the strengths that are unique to that particular community, that particular network of people and history and place, so that something can be developed that is unique to that place and faces the problems, because the problems aren't even necessarily the same. So yeah, sorry, I'll hop
No,
off my
absolutely.
soapbox and
No, that's really helpful. And actually, maybe because we just have a minute left, maybe we can end with Claire, like speaking of one of those particular topics that we want to jump into a little, which we don't have time to really delve deep, but around transportation. Obviously, that is one of the, an issue that there are a lot of potential solutions that have been implemented on the ground, but there's some challenges. And I'm just curious, Claire, one of the panelists did ask, like, what are some ways that we can be advocating for some solutions to these challenges, especially when it comes to funding? Maybe you could speak to that, and then we'll close up.
Yeah, I'd love to. So first of all, Josh, I love your soapbox, and I'm going to build on that and say that, there's like some cognitive dissonance around this at the state level, right? Because, the Rural Health Network Development Program is a beautiful example of a program that allows for building up bottom-up solutions. And over the course of my 12-year history with it, it's been nothing but cut from one year to the next. I mean, it's always on the chopping block. And it's a very hard program actually to talk about the return on investment. And that's what our elected officials want to hear is, what are the major changes across whole populations that are affected by this program? Well, that's the wrong question. I don't have a good answer to that, but I'm also going to challenge you to say that that's the wrong question. So we need to continue to do a better job speaking to the importance of investing in rural people and places, and argue that they're worth it. That those rural people and places are worth that investment, even if we can't count their numbers in the millions, and their acreage in the thousands. So that's a very quick answer. Super speedy on transportation. There's very little by way of institutional payers for transportation to, I'm just going to say a non-Medicaid enrollee. We talked about an aging population in rural areas. They're not great payers for your 65 plus crowd. So a lot of those solutions are, as we've talked about, homegrown and self-supported.
Great.
that is a whole other topic.
Yes,
We'll go into
exactly.
that another time.
Yeah, absolutely. And so we're just at the end of time, and there's definitely, it's looking to me from the chat, we weren't able to delve more deeply into some of the hospital issues, but that's certainly something that we'll look to follow up on, and hopefully have another event to dig in there, and to maybe dig into some of these transportation issues as well. So lots more for more upcoming sessions, but I just really wanted to thank our panelists. This has been a great discussion. For everyone who contributed to the chat, we'll be taking a look at that chat as a group, and we can follow up on some specific issues if we weren't able to cover them today. And please take a look at our website to see some of our upcoming events and offer us suggestions. So again, I really just wanted to thank Claire, Allie, Maria, and Josh for taking the time this afternoon. I think it was really enlightening for me, and I'm sure for our audience as well. So have a great afternoon, everyone, and we'll see you next time. Thanks so much.